Hey everyone, welcome to our deep study session on cardiogenic shock. You know, this type can be super tricky because the heart itself is the problem. So let's really master this so you never ever mix it up on the NCLEX. Okay, so here's the plan. We're going to completely break down cardiogenic shock so that you can walk into your exam and confidently answer any question they throw at you. We're going to get to the heart of the problem. Literally, it's a failing pump. And we'll do that by deeply understanding what causes it, how it looks different from other types of shock, the exact nursing interventions you have to know, and of course, what to monitor super closely. So, we're going to tackle this step by step. We'll start with a failing pump, then get into the signs of system overload. After that, we'll cover the critical fluid alert, which you absolutely have to know. Then, priority nursing actions, what you need to monitor, and finally, we'll wrap it all up with a quick-fire NCLEX review to really make sure it all sticks. All right, let's dive right in. First things first, what exactly is cardiogenic shock? Okay, this is the most important thing to get right off the bat. With cardiogenic shock, the body isn't low on blood. There's plenty of volume. The problem is the pump. The heart muscle is just too weak to push that blood forward. And because of that, cardiac output, the amount of blood the heart pumps out every minute, it just plummets. It's a pump problem, not a volume problem. Remember that. So what causes this pump to fail? Well, the number one cause, and the one you'll see on the NCLEX most often, is an acute MI, a heart attack. It makes sense, right? If the heart muscle is damaged from a lack of oxygen, it just can't contract the way it's supposed to. But it's not the only cause. You can also see it with things like pericardial tamponade, where fluid is literally squeezing the heart from the outside, or severe dysrhythmias that mess up its rhythm, or even infections like myocarditis that make the muscle weak. Basically, anything that seriously damages that pump can throw a patient into cardiogenic shock. Okay, so if the pump isn't pushing blood forward, you've got to ask, where does that blood go? Well, it goes backwards. It creates a traffic jam. And this backup creates two totally different sets of problems at the same time. You get signs of fluid backup, and you get signs of low blood flow going forward. And this slide breaks it down perfectly. Look, on one side, you have the backup signs. That's the fluid overload. The blood backs up into the lungs. That's where you get those classic crackles from pulmonary edema. It backs up into the veins, which is why you see jugular vein distension, or JVD. Then on the other side of the coin, you have the low flow signs. Not enough blood is getting out to the body. That's why the patient gets confused. Not enough blood to the brain. Low urine output. Not enough blood to the kidneys. And that classic, cool, clammy skin. It's two problems happening at once. All right, listen up, because this next point is absolutely critical. I mean it. This is probably the single most important concept that separates cardiogenic shock from all the other types of shock, especially when you're thinking about the NCLEX. Here it is. This is a massive, massive safety alert. In almost every other type of shock, like hypovolemic shock, what do? We pour in the fluids, right? Gallons of it. But with cardiogenic shock, giving IV fluids can actually make things much, much worse. You have to be so careful. And this really explains why perfectly. Think about it. The heart already has plenty of blood volume to pump. It just can't pump it. It's like pouring more water into a clogged sink. It's not going to fix the clog, is it? It's just going to make the sink overflow. And in this case, that overflow is happening in the patient's lungs. More fluid just increases the workload on a heart that's already failing. Okay, so if we can't just dump fluids into our patient, what do we do? What are the priority nursing actions? And let me tell you, for the NCLEX, the order of these actions is everything. So let's walk through this step by step. Remember this order. Step 1 always is your ABCs: airway, breathing, circulation. So we're going to apply high flow oxygen. We want to make sure that the little bit of blood that is getting pumped around is packed with as much oxygen as possible. Step 2 is fluids. But remember, carefully. We're talking small amounts and only if we think there's also a volume issue happening. Otherwise, we avoid them. Step 3, medications. This is where we bring in the big guns to support the heart. We give positive inotropes like dobutamine to improve contractility, basically to help the pump squeeze harder. We'll also use vasopressors like norepinephrine to get that blood pressure up. After that, step 4 is all about treating the underlying cause. If it's an MI, they're going to the cath lab. And finally, step 5, we might need to consider mechanical support, like a balloon pump. Okay, so we've done our interventions. Now, how do we know if any of it is working? What do we need to be watching for? It all comes down to one thing: tracking tissue perfusion. And you will be monitoring these things like a hawk. We're talking hourly. The big goals: we need that systolic blood pressure to get above 90. We are watching that urine output, looking for more than 30 ml per hour. And we're assessing their mental status, hoping to see them become more alert and oriented. Again, the big goals are good blood pressure, a urine output over 30 mLs an hour, and an improving mental status. These are your absolute best signs that our interventions are working and that the vital organs are finally getting the blood and oxygen they desperately need. Okay, I think you've got the core concepts down pretty well, so let's lock it all in. We're going to do a few NCLEX-style questions so you can see exactly how this stuff shows up on the actual exam. All right, first question. A client comes in after a severe MI. Their BP is 82/50, they have jugular vein distension, and you hear crackles in both lungs. So, what condition should you, the nurse, suspect? Think about that pattern. You've got low BP, a sign of shock, but you also have those classic signs of fluid overload. What does that scream to you? You got it. It's cardiogenic shock. That combination, that's the key pattern you have to recognize. Hypotension plus fluid backup equals cardiogenic shock. That's the classic presentation.
Okay, next one. Which order would you, as the nurse, question for a patient in cardiogenic shock who has severe pulmonary edema? Think back to that huge safety alert we talked about. What's the one thing that's usually good for shock but could be really dangerous here?
The answer is administer a 1-liter bolus of normal saline. You would absolutely question that order. Remember that critical fluid alert? This is exactly how they'll test you on it. Giving that much fluid would just worsen the fluid overload on that already failing heart. All right, next, the provider orders dobutamine for patient in cardiogenic shock. The nurse knows this medication primarily works by doing what? So what is the main job of a positive inotrope like dobutamine? What part of the problem are we trying to fix with that specific drug? The answer is by increasing cardiac contractility. Dobutamine is a positive inotrope. Ino means muscle, and trope means acting on. So it acts on the muscle to make it squeeze harder. It strengthens the heart's contraction, which is exactly what we need to improve that cardiac output. Okay, next question. What is the most reliable indicator that our interventions for cardiogenic shock are actually effective? So when you're at the bedside, what's that one assessment finding that really tells you, okay, the vital organs are finally getting the blood they need?
And the answer is increased urine output. A urine output of more than 0.5 milliliters per kilogram per hour is one of the best, most reliable signs that your patient is starting to turn a corner. It's direct proof that the kidneys are getting enough blood flow to start working again. It's a huge goal of treatment.
You did great. You've officially got cardiogenic shock locked in. Now, I'm curious, was that strict fluid caution a new or surprising concept for you? Drop a comment below and let me know. Next up, we're going to tackle distributive shock. Thanks so much for watching ClearPath NCLEX. If you liked this video, please give it a like and subscribe for the most high-yield content. And don't forget to hit that bell so you never miss the next game-changing NCLEX tip. Keep studying, you're doing amazing. I'll see you in the next one.